It is a huge honor today for me to be interviewing my buddy, George Freedman. Gosh, I think I've known you since day one. It's got to be going close to 30 years. George is a founder.
Don't say that. It makes me feel old.
No, you feel old because we're old enough to remember your name's George, that Georgie Porgy Puddin' Pie kissed the girls and made them cry. That's what makes us old, that we know that nursery rhyme.
Okay.
Dr. George Freedman is a founder and past president of the American Academy of Cosmetic Dentistry, a co-founder of the Canadian Academy for Aesthetic Dentistry, and a diplomat of the American Board of Aesthetic Dentistry. He's a visiting professor at the MClinDent program in Restorative and Cosmetic Dentistry, the BPP University in London. His most recent textbook, Contemporary Aesthetic Dentistry, is published by Elsevier. Is that how you pronounce that? Elsevier?
Elsevier.
Elsevier.
Originally a Dutch company.
Dr. Freedman is the co-author of 12 textbooks, more than 700 dental articles, and numerous webinars and CD, and is a team member of Reality. What's his name out of Houston?
Michael Miller.
Michael Miller and his wife, the orthodontist. What's her lovely name?
Ingrid Castellanos.
Oh, yeah. I love both of those guys. Dr. Freedman was recently awarded the Irwin Smigel Prize in Aesthetic Dentistry, presented by NYU College of Dentistry. He lectures internationally on dental aesthetics, adhesion, desensitization, composites, impression materials, and porcelain veneers. A graduate of McGill University in Montreal, Dr. Freedman is a Regent and Fellow of the International Academy for Dental Facial Esthetics and maintains a private practice limited to aesthetic dentistry in Toronto, Canada, with your wife, correct?
That is correct.
And tell him who your very famous wife is.
Faye Goldstep, who also lectures extensively and writes a lot. And the reason that she maintains her maiden name is so that people won't associate her with me.
And we just all had dinner a couple weeks ago at Joyce Bassett's house, who's the first woman female dentist president of the American Academy of Cosmetic Dentistry. And that's where I talked you into doing this podcast.
Yeah.
But Joyce won't do it because she's shy and bashful.
Somehow I don't think so.
She is. I know she's gregarious in person, but when you turn on the camera, she gets stage fright. So, but hey, today we're going to talk about major trends in clinical dental materials, major trends in dental technology, major trends in dental education delivery and formatting. What's hot and what's not in dentistry today, George?
Well, dentistry has been evolving very rapidly over recent decades, and it's often a challenge to dental professionals to keep up with all the developments that are occurring simultaneously in many areas of the field. It is important for the practitioner to identify important trends within the profession such that they can really maximize the time that they spend in learning and maximize the benefit of the money that they spend on upgrading. So let's take a look at clinical dental materials. I'm not using any materials that I learned about in dental school. In fact, even dentists who graduated only 5-10 years ago may not be using very many of those materials. Developments in dental materials tend to be evolutionary, though, rather than revolutionary. In order to be able to identify important current and future trends, the easiest technique is to examine recent directions of research, go to the IADR, go to the International Dental Salon, and to extrapolate them into the coming years, because this is usually the direction that it goes. For example, amalgam restorations, popular for more than a century, have largely been replaced by tooth-colored materials in the span of 20 years. Dental professionals seeking to improve patient treatment are searching for restoratives that can positively impact upon the health of the remaining tooth structure over extended periods of time, preferably the entire lifetime. We're seeing the introduction of bioactive restorations that, beyond just replacing decayed and missing tissue with a non-reactive material, interact with tooth surfaces to discourage bacterial activity and to strengthen the restorative interface. These bioactive materials represent both the near and the intermediate future. If we go into specific areas of restorative materials, bonding agents, most important for dentistry, first introduced in the 1970s, have gone through 7 major formative generations. Each successive adhesive generation has been more predictable and less technique sensitive than the previous one. 30 years ago, the resin practitioner was really faced with a variable chemistry set of materials to mix and match in very specific sequences in developing a micromechanical bond between the tooth and the restoration. Remember, these are not chemical bonds that we are working with dental adhesion. They're micromechanical bonds. Today, the dental bonding standard is the 7th generation single component, single step dental adhesive. Easy, fast, tooth friendly, and totally predictable. This is what we're looking for, where we cannot possibly, even inadvertently, make a mistake. What can go beyond single-step adhesives? Well, let me throw out my first future dental material of this discussion. Very simple, a 0-step adhesive. How would you like to see a 0-step adhesive? We have no steps. We've gone from 4 steps to 5 steps to 3 steps to 1, a 0-step.
Is this where you use the lightsaber?
Yeah, well, more or less. The technology, interestingly enough, is already available. It's being used in the 1-step resin cements where the adhesive is already incorporated into the cement. Why not incorporate the same materials into the restorative materials? There, in that fashion, we will not have any bonding. Now, why does this not happen? Largely because the bonding industry is a multi-million dollar dental business over the world, and companies are afraid to eliminate this particular area. So the next major evolution of dental adhesives, the 8th generation, will see the elimination of this treatment process as a separate step. So that's the first area in dental materials.
So the 8th generation bonding agent means that it's gone and now it'll be in the resin.
No bonding. So people who are experts in dental bonding will have nothing to talk about. It'll be like the Harvey. Remember the Harvey, the invisible rabbit that we had in a movie 40, 50 years ago with Jimmy Stewart? Oh, this is... I think the 8th generation bonding agent should be called Harvey because it's going to be invisible. It's going to be there in spirit, but not at all there physically.
And George, is it oversimplistic to say the only reason we need bonding agents is because the resins contract, and if they ever made a bonding agent that didn't contract, I mean a composite material that didn't contract, or maybe even just ever so slightly expanded, then there wouldn't even be a need for adhesive bonding anyway?
Well, the problem is more than just expansion and contraction. The problem is, to a great extent, the fact that the materials, the resin materials, don't really interact well with tooth materials. The materials that do interact with tooth structure, the glass ionomers, the pure glass ionomers, are not good in terms of wear in the long term. So if we want to get a really strong resin that can last for 10, 20, 30 years, and we want to somehow affix it to tooth structure, we need to have an interface. That interface has to be able to interface on the one side, interact with the tooth structure, and on the other side with the resin material. And that's what bonding agents do. So they're not just cushions for expansion and contraction, they're actually also dual interfaces which allow the incorporation of 2 dissimilar materials into a single material.
And who are you predicting that will come out with the first direct poster composite that you won't need any bonding agent?
Well, I can't tell you who it would be, but the companies that have the one-step resin cements, which do not require bonding agents, are the ones that are most likely to be fast-tracking this at this time. Now, indirect dental restorations are another area. They must be affixed to the remaining tooth structure somehow. The early luting cements were rather problematic, soluble in oral fluids, irritating to vital tooth structures like our zinc phosphate, unesthetically opaque, white in color, and difficult to mix properly. You have to really learn how to do it. Since 1990, resin cements have become dental standards. The early ones were difficult and problematic to mix, too, and required many separate steps. In recent years, the auto-mix one-step resin cements have simplified the final indirect restorative phase completely. While some of these materials are reactive with two structures, they do not chemically bond to all restorative materials. Soon the incorporation of silanes and other ceramics and metal catalysts into the chemistry of the one-step resin cements will securely adhere indirect restorations to tooth preparations, developing a true monoblock. And that way, again, you get the crown, you have the tooth, you put the cement in between, the tooth is wet with water, not with saliva, and 4, 5, 6 minutes later, just make sure that you remove the excess. These materials are already here now to a certain extent. The incorporation of silanes and other bonding agents which will work with zirconia and alumina are what's missing in the cements. Again, who will be the first? There are a number of companies. I suspect when we see one, we'll see 5 or 10, because much of the development of dentistry is me too. As soon as one company comes out with it and literally takes the first big step, everybody else follows and says, "Okay, yeah, we're here too."
I agree. Lehigh Iacocca only had the only minivan for 1 year, and then the next year, all 9 major car companies rolled out a minivan.
There you go. Now, there are also major trends in dental technology, and this is probably even more advancing, more radical than the advances in materials nowadays. The progress in dental technology has been revolutionary as well as evolutionary. We have acquired and adapted relevant equipment for various segments of the medical field for the most part, as well as developing new methodologies from within dentistry. If we wish to predict the technological direction of dentistry, it's simply a matter of looking at the proven medical gadgetry and to imagine its focused application in the oral cavity. So if you look at what medicine is doing today, you sort of see what we'll be doing in 5 or 10 years from today. Typically, medical innovation precedes its dental counterpart by anywhere from 5 to 20 years. Why does it take us so long? Because the dental market is much smaller than the medical market, and it's less profitable for companies to develop that methodology and technology for the dental field. Dental radiology, for example, has changed very little since the times of Röntgen, about 125 years ago. The introduction of digital radiography reduced patient radiation exposure, added the ability to manipulate diagnostic images, and simplified data storage. In less than 25 years, digital radiology has redefined dental diagnostics, right? As we move confidently and more affordably towards mainstream tomography, the dentist will begin to view both health and disease very differently. The next decade will see the arrival of three-dimensional diagnostic standards, where the two-dimensional X-ray, whether analog or digital, is basically passé, and we're looking at three-dimensional examination. We don't have to guess which root is infected. We don't have to guess where the problem lies in the bone. We know because we're looking at it three-dimensionally. The practitioner will have the opportunity to specifically locate disease and examine the generalized health status using three-dimensional modeling. Rather than a three-dimensional superimposition on a two-dimensional film or screen, requiring the educated guess I mentioned before, tomography enables us to the most conservative, direct diagnosis and treatment possible. And this is here today. It's only going to get better. It's also going to get cheaper. Today, well, let's say 5 years ago, we were looking at $200,000 for a tomogram. Today, it's half of that. In another 3-4 years, I suspect we'll be in the $25,000 or less range, basically making it possible for every practice to have a tomogram. The rise of oral cancer in groups not previously considered to be risk, young non-smokers, non-drinkers, and females, is rather alarming. If we do a rapid visual scan of the cavity during routine examination, it may disclose suspicious tissue or something that may have begun at the surface. Unfortunately, many precancerous epithelial cells and lesions occur below the tissue surface at the basal membrane. You can't find it. You can't see it. These subsurface abnormalities are invisible to the naked eye until they grow through the epithelial layer, at which stage the best opportunities for early discovery and treatment have been lost. The recent combination of high-powered LED lights and innovative filtration utilizes natural tissue fluorescence to identify clinically invisible anomalies. Cancers and precancerous epithelial lesions down to the basal membrane can now be identified and mapped and followed up with a biopsy and treatment. Technique is non-invasive, not unpleasant. As such, it is well accepted by patients and sets the standard for diagnostic techniques of the future. Where is this in the future? It's not. It's here. It's here today. We have a number of products out on the market, but the uptake by the dental profession is somewhat limited. There aren't a lot of these units available. You can't really tell very much in a 3-second scan of the oral cavity when you're looking through and there's perio paste or prophy paste and all sorts of other stuff, blood and saliva in there. But with one of these diagnostic devices, like the DOE, dental from Dentlite, and which is the Vel scope units, you can immediately tell if there's an abnormality. It doesn't mean that it's cancer, but you can immediately tell what it is, that it's a problem that you should look at further. One of the things that drives our practices is caries detection. It's the cornerstone of the dental practice. The earlier the decay can be identified, the earlier and more conservative the treatment for it. The traditional methods for examining tooth surfaces and confirming dental caries are neither effective nor beneficial to the patient. While the overhead operatory light illuminates dentition well, the practitioner has two basic options. If the surface is white, it is healthy, and if the surface is dark, it is decayed. There's no allowance made for caries that have been arrested and for discolored but healthy tooth surfaces. That's the old style. Oftentimes, the explorer was jabbed into suspected caries to determine the hardness of the tooth surface and its extent of decay. You and I were taught to do this in dental school, Howard. Not only was this very uncomfortable for the patient, often eliciting howls of protest, but it was also iatrogenic, serving to spread disease very effectively from one tooth to the other. The introduction of fluorescence detectors has vastly changed the parameters of caries screening, and today, totally non-invasive techniques visualize the tooth surface in the mode to locate problematic areas, and in an analysis mode to pinpoint the severity of the lesion and the need for treatment, which can be visible in distinct colors. This diagnostic modality focuses the dentist onto areas that require treatment and quantifies the disease status. Tooth restorative interfaces are typically very difficult to evaluate for breakdown, as amalgam and composite can confuse the visual interpretation of the practitioner. Fluorescence caries detection eliminates the doubt totally. In the near future, the blending of innovative caries detectors and small field tomography will yield diagnostic capacities that are unimaginable even today. And the caries detection that I'm talking about, it's available today. It's the future. But in North America, literally hundreds, at most 1,000 or 2, have this. Less than 1% of the practitioners have equipped themselves with these fantastic tools that should be in everybody's practice. Dental lasers have also revamped minor surgery in the dental practice. Benefits of this technology were evident many years ago, but the lasers themselves were cumbersome, large, difficult to use, and far, far too expensive. My first dental laser cost $53,000, and later on, lasers were over $100,000. The diode revolution transformed the playing field, reducing lasers' cost to under $10,000 and often under $5,000. Wow, what a difference! Floor model lasers became countertops, handheld. Complex protocols are totally simplified to presets, and prices tumbled from a mini mortgage to that of a handpiece. Literally, as Faye Goldstep says, the laser is the soft tissue handpiece. Laser utilization mainstreamed from hundreds to tens of thousands of dentists. The lower prices and the easier use just made it more practical. The advantages of laser procedures extend into every branch of dentistry, from orthodontics to prosthodontics to endodontics, and the proactive impact of these minimally invasive technologies is just beginning to be felt in preventive dentistry. When I've got a subgingival margin, I can restore it, allowing blood or clavicular fluid to seep in, knowing that that restoration will never work in the long term. Or I can dry it out, keep it dry with a laser in a matter of a few seconds, and get a perfect subgingival margin, which is better, of course. That is by far the better way to do it. We've already seen lasers used to treat hard tissues such as enamel, dentin, and bone. These directions are likely to expand to an area where much of the surgical energy that is used for oral treatment will be light beam rather than rotational. Imagine that. The drill will not be a drill, it'll be a light beam. And in terms of hard tissue lasers that do remove hard tissue, there's one that's going to be introduced at the Greater New York meeting that's going to be in the $50,000 range. Every single other one has been over 100, so the prices are just tumbling. And that is going to be AMD. The Picasso folks are introducing that hard tissue laser. And it's price-wise, it's definitely interesting, and we'll see the units when we're in New York and go from there. Now, like mediated therapy can be more focused. It's less harmful to the immediately adjacent tissues and offers a more rapid and improved healing. It's readily predictable that the combination of tomographic diagnosis will be used in the near future to guide precise laser intervention, where we're working internally at the apices and so on, even not using our hands, using dentist-positioned robotic units, as is common in medical surgery in the treatment of dental disease. Photoactivated technologies may be in their infancy, but research is pointing to great benefits for both patients and dentists. Typically, these techniques are highly proactive and minimally invasive of tissues, both hard and soft. The general concept is that various wavelengths of light can stimulate desired responses in natural tissues, or alternatively, targeted tissues can be seeded with specific receptors that in turn are activated by a light beam. There's a lot of cancer therapy that is following this direction. Specific wavelengths can be focused at the tissue surface or perhaps below the tissue surface to encourage healing by stimulating beneficial responses and leading to the resolution of inflammation. Big problem in dentistry. Future enhancements include delivery modes and targeting technologies that will further refine this highly desirable treatment approach. This is being used a fair bit in Europe and is just starting to come to North America. And it's certainly an area to watch. Now, dental impressions, as recently as my time in dental school, involved rubber base. I don't know if you remember that.
Yes, I do.
Inaccurate alginates and a whole host of memorably unpleasant techniques, both for us and for the patients. The great progression to polyvinyls, polyethers, enhanced polyvinyls, and precise alginate derivatives have all made dental impressions pleasant for the patient and predictable for the practitioner. Over the past decade, dentists have begun to scan prepared teeth optically rather than impressing them physically, and today this is widespread modality. Initially, it was very expensive. The scanners were exorbitant, but these technologies are now firmly within financial reach. Unfortunately, many of them are priced at the level of how much money the dentist can save by not doing a conventional impression, rather than the cost of the technology itself. When we have more competition in this area and more companies vying for the market, it'll allow the price to come down to where it should be, which is probably between $5,000 and $10,000 for a scanner, which will really make it practical in the dental practice. The predictable trend is that optical impressions, readily obtained and transmitted to the lab online, will entirely replace traditional impressions in the near future. Now, having discussed a few areas, not by any means all the areas of innovation, but certain areas that just grabbed my attention, I'd like to talk about dental education. It's something that is mandated for all of us, and really we should be doing it. That's part of our life as professionals. We shouldn't be stuck on the day we graduated. We should be continuing to expand our knowledge base as science and technology goes forward for the benefit of our patients and a little bit more quietly for the benefit of ourselves as well. In using technology, we become more efficient, more practical, more productive, and that's always good for the practice and the bottom line. Education is always changing. It is highly responsive to the needs of those interested in acquiring new information and their current learning preferences. So there'll be changing habits in education, and the provision of education will follow them. Education is also highly dependent upon the techniques and the settings of those in a position to provide this new information and their current preferences. Continuous learning is, or should be, the very basis of every practitioner's professional commitment to dentistry. Typically, at any given time, approximately 30% of dentists are actively seeking to advance their knowledge. They read magazines, books, they attend conferences and lectures, they participate in hands-on and extended programs. They, in turn, are in a position to offer their patients the best and most current treatment options. Unfortunately, the 30% tends to be the same group of dentists over time. You see the same faces at meetings over and over. What about the other 70%? Where are they getting their education? Well, I'm not even going to address that. Fortunately, licensing laws and regulations require all practitioners to be relatively up-to-date with knowledge, targeting the remaining 70% who are less proactive in their educational activities. Educational patterns are changing for a variety of reasons. In the recent past, education was the exclusive domain of academics, academic teaching institutions, and dental conferences. Over the past 2 decades, focused organizations such as the American Academy of Cosmetic Dentistry, American Society for Dental Aesthetics, and others have focused on leading-edge topics and techniques far more quickly than was possible within academia, and education that was simply not available elsewhere. This attracted individuals who were interested in providing specific treatment modalities to their patients. The rise of specialty and quasi-specialty meetings in cosmetics, orthodontics, implants, sleep apnea, etc., has been a testament to dentists seeking to expand their practice horizons. The larger meetings are likely to continue to decline slowly until they reinvent their message to the practitioner, as they tend to every 10 or 20 years. The smaller, more focused, more information-aggressive meetings are likely to maintain their attendance within their special interest groups and possibly grow. Other factors, non-dental in origin, are also having an impact on dental education. Travel to meetings is more difficult, more time-consuming, and more costly. Taking extensive time away from the practice is cost-prohibitive as well. So, in addition, many of the presentation offerings at meetings are of marginal interest to the clinical dentist and may be repetitive of knowledge already acquired, and may be in mandated topics that are of no interest to anybody except for the bureaucrats. Dental manufacturers and distributors, long the bankrollers of dental education, are also having a more difficult time participating and paying for the vast proliferation of dental meetings that you see in every state, every country, every city. The rise of web-based education has again changed the playing field. And Howard, you're very familiar with this. You've been one of the leaders for many, many years. Firstly, the quality of online programming, not subject to peer review and evaluation, is very uneven. You have good, you have great, and you have bad. Excellent programs are found side by side with time wasters, and there's little, if any, standardization. The other concern with online education is that the providers may have specific selling points and marketing objectives. This should not be a problem as long as the relationship is clearly identified, which all too often it is not. The cost of taking these programs ranges from the ridiculously expensive to totally free. The true value of for the dental practitioner is virtually impossible to pinpoint until they've already gone through the education. Thus, the online education arena is a potential minefield for the unsuspecting dentist. Fortunately, there's a system of organization, definition, and evaluation that has come on to online programming. For the first time, university-based certificate, diploma, and master's programs are being offered entirely online. These are comprehensive, long-range programs that compare favorably with the attributes of their live attendance, certificate, master's, and such programs, and more. Typically, their faculty members are leaders in their fields, offering the latest materials and techniques. There are more and more relevant lecture sessions. The literature reviews and searches are more focused and detailed and are examined for up-to-dateness on a regular basis. Treatment planning exercises have been transformed successfully to online platforms. In many disciplines, clinical cases are required from the participants, some in step-by-step detail, showing exactly how good the practitioner's command is of a particular technique. Most important to the clinical dentist, all of the education is available online at any convenient time. Practitioners do not have to give up their practices for 2 or 3 years or even valuable chair time. Almost all of the educational processes can be completed at the discretion of the attendees at their convenience, in the comfort of their practices or homes. Up until now, the only missing link in online education was the personal exchange between teachers and students. Today, the availability of online e-tutorials and VOTS or VOTS, virtual online teaching or virtual over-the-shoulder teaching, has filled the gap. High-quality simulators that are affordable for individual dentists enable private hands-on education for practitioners within their own office. Since physical location equipment requirements are lessened, the costs of these university-based certificate, diploma, and master's programs are more favorable. We're looking at costs for a master's in the $50,000 area from beginning to end, and a variable time to complete it. This is easier for the dentist to cover while in full-time practice. Overall, online education is easier and more convenient to the dentist, but the dentist must select the right program for their own needs and purposes. The impersonal large classroom format of dental education is largely passé. Dentists are demanding meaningful personal contact with their educators to make learning time more relevant to their own practices. The value of engaging the instructors in one-to-one discussion cannot be overstated. Thus, smaller, more focused educational events are increasingly popular with the profession. Participants engage with a single instructor for the entire day, not, or perhaps a part thereof, as they become more familiar with the delivery format and the thought process of the teacher. The process of information transfer to the dentist and the small audience increases in effectiveness. Where there's opportunity to immediately try the materials and technologies discussed in a hands-on setting, the learning experience is further enhanced. At one time, dental lecturers could get away with presenting beautiful pictures of birds, flowers, sunsets, and their cars as a significant part of their allotted time. Now, as dentists have more choice in sourcing their education, they demand that teaching be focused, specific, up-to-date, and relevant to their clinical practice. More stuff and less fluff accurately describes the successful dental educational presentation. There are also major trends in the evolution of patient treatment options. The major directions for patient treatment all involve 3 underlying concepts: proactive, diagnosing and treating problems early or before they start; minimal, treating problems as conservatively as possible; and comfortable, ensuring that the patient hyphen consumer has a pleasant or relatively pleasant overall experience. These concepts apply to the traditional pursuits of the dental practice, such as direct and indirect restorations, endodontics, orthodontics, implants, everything. Dentists who do not offer and promote these parameters to their patients will find themselves far less busy than they would like to be. There are novel areas where this can take take responsibility if they choose to do so. Treatment of TMJ, sleep apnea, bad breath, perioral dermal treatment, smoking cessation, nutritional counseling, among others, are areas where the dentist can break in. Of course, there are a lot of people competing for this area, and in some areas, other specialists have made sure that dentists do not have access to these treatment modalities. But each of these treatment area extensions can have a major positive impact on the dental practice. Just think of all the benefits that tooth whitening brought to the profession over the years. One real cause for concern is the pressure on the dental profession and the surprising willingness of certain dental professional bodies to allow devolution of dental services and responsibilities to groups that are not properly trained for these tasks. The pressures on the politicians who enact these rules is financial and electoral. They see dentists as rich and powerful, and it's a group that is easy to bring to their knees because it's a small group and very unvocal, very unpolitically involved. In fact, most dentists are small business people who are making a comfortable living but not getting rich. The current costs for dental education are so high that many young practitioners will spend a significant part of their working lives paying off their academic debts. Organized dentistry and its elected leadership must serve to protect the public and the members of the profession by opposing and preventing the devolution of unsupervised services to the less trained and less capable, no matter how politically attractive that might be to people who can do it from a political perspective. Now, patients get more excited about certain treatment options than others. Tooth whitening and porcelain veneers, cosmetic dentistry, have been extremely popular and have propelled the recognition and acceptance of the dental treatment body more than all the other factors combined. The use of dental appliances for sports and more comfortable sleep have increased public awareness and familiarity with the dental professional and dental treatments. The role of implant dentistry is more than 2 decades old, yet this modality is just beginning to hit its upward curve. Major barrier to the extensive use of implants to restore missing teeth and lost function has been price. The big 5, 6 hardware manufacturers just put the prices so high that many patients were priced out of the market. The technical and clinical problems were solved long ago. The unrealistically high expense of the implant hardware combined with the early uncompetitive positioning of the surgical, restorative, and laboratory fees served to limit patient acceptance and utilization. Now, as implant hardware costs have plummeted because of competition, the patents expiring, and more companies in the field, dentists and technicians are competitively seeking to find reasonable remuneration levels for implant-associated procedures. Patients are benefiting, and increasing numbers are choosing this excellent treatment modality. Once the market has essentially developed its own appropriate treatment fees, implants are going to be the norm rather than the exception in the replacement of missing teeth. One also has to wonder what treatment choice ramifications will be for a patient with a badly broken down tooth in the near future. When the cost of an endodontic treatment plus post and core plus crown are equivalent or less than the cost of an extraction, implant, and implant crown, which will be the most conservative and longer lasting option, and which will be more popular as a patient selection? I think we're going to see over the near future a major decrease in endodontics, especially heroic endodontics, and a major increase in implants for these very situations. The most dramatic trends in patient treatment options will occur as a result of combining existing and new technologies to make dental practice better, faster, and easier. We have seen this with the increasing utilization of implants for denture stabilization. This is greatly underused. People who do use it are making a lot of money. They're very busy. And don't forget, the dental population, or at least the entire population, is about 30% edentulous in most areas of the country. The people who are seeking the denture stabilization with the smaller implants, the immediate implants, are also the baby boomers who have a lot of money. So the money is there, the intent is there, just that many dentists have not recognized this as a good part of their practice because it's very lucrative. Currently, the use of three-dimensional tomography to accurately plan implant placement facilitates placement. Comprehensive jaw movement analysis precisely records the state and the mobility of the mandible joint to optimally design prosthetic treatment in a fully functional and comfortable position. Adding sensors and actuators to dental sleep appliances will improve the patient's nocturnal rest and waking hours. The age of synthesis, putting independent scientific and clinical knowledge together, is upon the dental profession. Now, a couple of more areas, trends in the evolution of the dentist-patient interaction. Unfortunately, practice success has always depended on the interaction between the dentist and the patient, and the staff, of course. This is unlikely to change in the near future or the far future. However, the dentist-patient relationship has been changing for many years and is likely to evolve more rapidly in the near future. The patient today is largely informed, but not always well informed. The information readily available on the internet is rarely vetted for accuracy or fact. In fact, misinformation is much more likely than real understanding. Patients, however, assume that they are knowledgeable and will often confront the dentist with their knowledge, gleaned from the experts on the internet. It is essential for the practitioner to correct the patient's misinformation, but without offending or belittling the patient. This is something that can be a difficult task on occasion. It is far better and easier to have an effective educational program available for patients in the reception area and in treatment rooms and while waiting for procedures. This proactive transfer of information may offset some of the incorrect data that is being gathered by the patient and may lead to questions that will ultimately encourage appropriate and additional incremental treatment. Increasingly, the dental team is focusing the patient's home care by recommending specific maintenance procedures. For example, patients who do not respond to flossing, that's the vast majority, are often more amenable to something called water flossing. Water flossing is something that we were told in dental school 40 years ago was a joke. We saw an article just 4 years ago which totally turned that on its head. And it seemed that there were a lot of potential benefits. We started using water pick or water flossing at home, and we liked it so much. Basically, it was more effective than flossing, although we used the two of them together, that we started recommending it to the patients. And patients, number one, responded much more positively to it, and number two, they were also keeping their mouths cleaner. So we're now recommending this as a major thing to our patients, and dentists who want to make sure that their patients maintain their oral cavities properly would be wise to do the same. Individuals with halitosis and or long-term periodontal disease due to poor oral hygiene may accept medicated rinses on a regular basis. Those with excessively dry mouths are actively seeking oral moisturizers, and there are a number of those on the market, and we're the gateway to that as dental professionals. More and more home-applied therapies are available on the recommendation of the dental team, and the successful practitioner will use every possible device to improve the patient's oral health in the long periods between recare appointments. This is when we don't see the patient, when the patient only sees themselves, and we have to give them every possible tool to make that work. What are some of the new clinical standards in the next 12 months, in the next 5 years? Well, in the next 12 months, we are likely to see a major restructuring of the dental implant segment, the cost of implants to the dentist and patient, and a significant increase in their popularity and utilization. The percentage of dentists sending optical impressions directly to the lab will grow. Bioactive restorative materials will be the latest and the greatest in restorative dentistry. More restorative materials will be self-adhesive, heralding the advent of the 8th generation or no adhesive at all. The relationship between oral health and systemic health will become more firmly established in the public's mind, encouraging better oral health care and more dental consultation, and for the forward-looking dentist, more patients, more business. Over the next 5 years, even greater changes are expected. The diagnostic and surgical technologies required for implant placement will make the process so predictable that most general practitioners will choose to embrace the surgical procedure rather than to send it out to specialists. Oh well. We'll keep the money and the treatment in our pockets rather than sending it to somebody else. Dentists will not only take impressions optically, but will utilize 3D modeling and printing to create the required shade-matched crowns and bridges within minutes right in the practice. In fact, many of the CAD cams today are already obsolete. 3D printing is the way to go in the future. Just a few days ago, I saw filling material that is printed out depending on the cavity shape and size that has been scanned in, and the printed restoration is actually antibacterial. Who knows what the future will bring? It'll be good, but we're not entirely sure of what it's going to be. Remineralizing and regenerating restorative materials will build nature-mimicking structures that closely resemble natural teeth. A variety of systemic diseases will be treated orally by the dental practitioner. And more importantly, we as dentists will become the gateways to diagnosis of systemic diseases through oral tests that we can administer. The past 100 years have demonstrated a rapid growth in dental technology and an even more rapid development of dental materials. The past 2 decades have offered quantum leaps in the restoration of oral health, function, and aesthetics. By simple extrapolation, the future is golden for the dental profession. It is an exciting time to be a dentist.
George, you're the Beethoven of dentistry, buddy. You just played an entire concert. That was amazing.
Well, thank you very much.
I'm so glad that we met up at Joyce Bassett's dinner the other night, and I was able to twist your arm to give me an hour of your most precious time.
You never need to twist my arm, just ask.
All right, and I would also love to interview your wife. Do you think Faye would be up for this?
Yes, she is. Contact her, and she'll be happy. Having been married happily for 5 years, I'm 38. I know better than to make decisions for her, but I know she'd be thrilled to work with you.
And how's your daughter doing?
She's doing fine. She's actually in charge of distributing canine toothpaste.
For dogs?
For dogs, yeah, in Canada. Human toothpaste cost $3, $4, $2. The premium ones are $10, $15. Dog toothpastes start at $25. It's amazing. And she has the best one on the market, so it's a product that is very good. It's called Pet Smile. Makes your pet smile. You don't have to brush your dog's teeth. Just get the material into their mouth, and they'll have fewer visits to the vet for tooth cleaning because the whole pellicle deposition on the tooth is interrupted. It'll keep dogs healthier, happier, and with fewer tooth cleaning appointments, which are not only possibly risky, but they're also expensive. For example, how much do you charge for a cleaning? $150, $200?
Yeah.
You know how much vets charge for a cleaning?
How much?
$500 to $800. I'm giving up my human dental license. I'm going to become a vet.
George, if she runs into anybody, both of her parents are world famous dentists. If she runs into a dentist vet, or either a vet that does dentistry or a dentist who does veterinary, whatever, I've never podcast interviewed, and I never made an online CE course with veterinary dentistry. So if you run into any names, that would be really fun and exciting.
Veterinary dentistry is a really rough business.
Why is that? Oh, rough, as in rough, the dog. Is that what it was? A pun?
Ah,
I loved it. But really, she might run into one. She might run into
oh, yeah.
someone. Yeah, if she does, turn me onto the lead. I've always been, every time I see an article of some dentist doing a root canal on a lion in a zoo, I always find that incredibly fascinating. And also, I want to ask you, my last question is, how much money would I save if I traded you my 4 boys for your only daughter? Could we negotiate this?
Daughters are a lot more expensive than sons. I have to tell you that.
But I got 4 sons. Do you think it'd be an even trade, or do you think I'd even lose money?
You'd probably lose money on the deal.
All right,
but I'm happy to entertain it.
Okay. Well, thank you so much for your time, George. That was an amazing hour.
Pleasure. Thank you for the opportunity.
All right, I'll see you in New York.
In New York. Are you coming to the IADFE?
Yes.
Good. Have you nominated anybody?
I have not.
Well, do you know any deserving dentists who are leaders in their profession, who've contributed, who do interesting stuff? Because you're a fellow of that group, right?
Yes. Okay, I will work on that.
Okay.
All right,
Take care.
You have a great day. Bye-bye.